I'm Christie, and we've got Dr. Weltman with us from Sydney today. Thank you so much for taking the time to join us. I know you've had some technical difficulties, you were saying, and that can be a real challenge when things aren't going as planned.
That's working now.
Good. Usually mine decides to do a bit of an update when you're trying to get logged on quickly, and it's saying, no, I'll just take my time and do an update. So a little bit of housekeeping before we start. Just remember that these Q&As do not take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. So often you'll see that what we'll do is we'll give a bit of background and read the question, but the doctor will generalise the answer for you to provide some general medical information on it. I'm recording the session here within Click Meeting, which will upload to our YouTube channel. But just be aware that on the right-hand side of the screen where you can see our names and the chat for putting in questions for us, I'll give the question verbally to Dr. Weltman, so that part's not recorded, so we can ensure a safe space here whilst we're doing the Q&A direct. So I'm going to get started with the questions that I've had sent in so far this week, but please just, if you're in the room and you have any questions, just pop them in the chat for me and I'll keep an eye on them there as well. So our first question, I'm actually going to sneak an extra one in while I'm talking about our zoo, because I was speaking to someone last night who was asking about, it's the question that we get quite a lot about, what's the best time to take your Urzo? Should you take it all at the same time? Should you take it throughout the day? Should you take it with food? So I thought it was just worthwhile mentioning that again.
Mm-hmm. I think our viewpoint there, I don't think there's an absolute correct answer, because those studies were never done in those days when they looked at medicines, and it was designed as a 3 times a day dosage, and that's how the clinical trials were done. So we don't know if taking it another way is as good. I like my patients to strictly take it 3 times a day, preferably on an empty stomach, so they get full absorption of the medication. It's not a medication that usually upsets the digestive tract. So if they tolerated to take it without medication 3 times a day, without meals 3 times a day, and if you can comply with that, once I'm happy that the ALP and the liver tests have responded well and are normal, it's hard to remember in this day and age for people to take it 3 times a day, and a lot of people find it really struggle to comply with the middle of the day dosage, particularly if they're working and are busy. Mm-hmm. So then we say take 2 and 1. That's my preference, but you might get a slightly different answer from a few different experts. But we're basing it, we can only base it on what's been studied, and the studies were all at what we call a TDS, or 3 times a day dosing regimen. But that's what I do.
Great, thank you. And we've also got a question, someone asking if they can take taurine with Urso.
Oh, I don't think I'd see a problem with that. I think that would be okay. Yes, I would think that should be okay.
Great. So a bit of background in this one. Patient who was diagnosed with PBC May 2024 and also just diagnosed with rheumatoid arthritis July 2025, also suffering with dry eyes. They're taking Urso, Everall, HRT patches, and they're suffering from fatigue, joint pain, muscle pain and weakness, and often suffer from flu-like symptoms, which I guess are flare-ups. Not sure which or both are causing symptoms. And the question is, what treatments are the safest for rheumatoid arthritis when you have PBC?
So that's hard to unravel because everyone's going to be a bit different, and some people might have more serious rheumatoid than others, and some people might have more serious PBC or more aggressive PBC than others. So it really has to be guided by experts in both areas, and I assume there are experts involved in both areas, specialists who have specific interests in those areas. And it sounds like that individual possibly has Sjogren's as well, with the dry eyes, which is often associated with PBC and can be associated with rheumatoid too. And they may have other autoimmune diseases. It's harder to finesse, if one's being quite frank, it's hard to be nuanced about the fatigue and all the aches. Could it be driven by PBC? Absolutely, yes. Could it be driven by the rheumatoid? Yes.
Mhm.
And it could be driven by both, or some of the other background health issues as well. So it's, if one's being quite frank, you're probably not going to properly unravel that sort of complexity. If someone came to me and they're already on rheumatoid medications, quite likely some sort of immunosuppressive drug, but maybe not, maybe a simple drug like cilazapyrin, which is not immunosuppressive, but they may very well be either on oral immunosuppressives or one of the newer biologics or JAK kinase drugs for rheumatoid. Then I would accept that that's what they're on. I would be a bit wary about methotrexate, because methotrexate's often used in rheumatoid, and methotrexate is potentially hepatotoxic over many years, probably not in the short term. And we don't see as much methotrexate toxicity these days as we used to see in my earlier career. And that's because I think it was overdiagnosed. There were other liver diseases, like fatty liver disease, that they didn't understand. So we actually see very little methotrexate toxicity these days, and methotrexate is still widely used. But I would still indicate to the rheumatologist, would there be other options beside methotrexate? If there's no other options, we would live with that. And I would treat that type of patient in the same way with URSA. If URSA works, well, then, and brings the liver disease and the PBC under control, and good disease control, then the focus should be on the rheumatoid and allow the rheumatologist to give what's ever necessary, with that one caveat about being very careful, and which we're going to monitor that individual quite frequently with liver blood tests, so we'll know if the methotrexate is causing toxicity. But all those other modern drugs, like all these biologic drugs and JAK kinases that are often used in rheumatoid or more aggressive rheumatoid today, should not upset the PBC. If that's where this question's going. It may be slightly different if the PBC is diagnosed first. I would treat the PBC, and in some ways I would treat it with URSA, and if I needed to get a second-line agent, that's fine too. And then the rheumatologist, hopefully I'd have the disease under control. The rheumatologist would have a free range to do whatever they want in that scenario.
That's great.
And I've had this type of patient before, and so it's just important that the two specialists are communicating correctly so that everyone's on the same page.
Great, thank you. Again, a little bit history, and then we'll generalise the question. So we have a patient who's had a biopsy that was suggestive of PBC, but was an AMA negative. DILI has been ruled out, already on 3-monthly rituximab infusions, increased from 6-monthly 1 year ago. Prednisolone and Cellcept for other autoimmune diseases, rheumatoid and myasthenia gravis. ALP has been mildly elevated for 2 years with moderated elevated GGT. Since having the gallbladder removed, had pressure on the upper right quadrant. If I stopped my previously methotrexate or current Cellcept, my ALT also increased to 4 times the normal, and GGT and ALP increased even more. Started a trial of URSA, and within 10 days, ALP and GGT were normal range for the first time in over a year, reducing by 40 from previous tests. The questions around, does this sound like PBC, or maybe even PBC with AIH overlap that has been masked by my immunosuppressants?
Okay, so let's say this does sound like PBC, and there are some newer, not brand new, but newer antibodies that can be looked at that are associated with PBC in AMA negative patients, so that sometimes is helpful. It does sound like PBC in terms of the biopsy and the URSA response. Obviously, I'm not going to comment specifically because I don't have access to all the data and the liver biopsy, etc.
Yeah.
But that part of it, yes, it does sound like PBC. It sounds like in that scenario, URSA would be a good and simple addition to the more complicated medical history and more complex drugs like rituximab that are necessary for the other autoimmune illnesses. It is possible that autoimmune hepatitis is there. One will probably never know unless it's active. It's clearly not active, and it's probably PBC predominant anyway. But autoimmune hepatitis would probably respond very well. It's a bit of overkill, but it would probably respond exceptionally well to rituximab anyway. So we use that sometimes in challenging autoimmune patients.
Okay, thank you.
Autoimmune hepatitis patients, sorry, to be more precise.
Okay. Patient asking about, had an elastography scan, came back with a 12.1 score. They've now told me it needs to be scanned every 3 months. Why is this? So just talk about maybe what the score is.
I'm just going to shut the blinds here. Sorry,
yeah,
it's just too much glare. So the FibroScan reading of 12.1 is very high. So it indicates a high likelihood of very significant fibrosis. Your doctors may think there's cirrhosis, and that's why they want an ultrasound frequently. Is that the question?
Yeah, they've had an elastography scan. It came back with 12.1.
Yeah, so if you've got cirrhosis of the liver, we'd probably use a higher cutoff for that, slightly higher cutoff. But that's what your treating medical team think, that you might have underlying cirrhosis from the PBC. And if anyone's got cirrhosis from whatever cause, they're at increased risk of hepatocellular or primary liver cancer.
Mm-hmm.
PBC is less risky than, say, alcoholic liver disease or hemochromatosis or some other, or hepatitis C in terms of liver cancer, but it's still a risk factor if you're cirrhotic. So if we see anyone with cirrhosis in our clinics or practices, the standard of care globally, the standard of practice is to do a 6-monthly ultrasound to screen for liver cancer, and a 6-monthly alpha-fetoprotein blood test to screen for liver cancer. So they're simple screening tools that'll pick up. The idea is that one will pick up a very early liver cancer that's quite treatable and correct, manageable, as opposed to waiting for someone to get liver cancer, in which case, more often than not, it's not curable.
And so the extra scans for extra monitoring in this term.
It's about liver cancer monitoring, and I'd be having that discussion with your doctors and very clearly articulate, why do I need this every 6 months? I think that's the answer you're going to get. But you should be able to have that discussion with your own doctors, and they should be able to explain that to you.
That's great, thank you. Next question, I was wondering if it's okay to take over-the-counter magnesium and or calcium if you have PBC, and if so, what is an appropriate dose?
I'm not going to comment on appropriate doses because I don't supplement people with calcium and magnesium, but and I'll probably use standard doses you buy in a pharmacy, packaged standard tablet doses. And yes, it would. There's no issue with having magnesium and calcium supplements, depending what you need them for. And in fact, some women need the calcium supplements because they may have some osteoporosis or osteopenia, which has been enhanced by the PBC.
Great, thank you. Again, a little bit of history for this one, and then we'll generalise the question. Diagnosed with PBC 2.5 years ago, responded well to Urso for 2 years, then needed OCA added 2 months ago. Main symptoms are fatigue, brain fog and joint pain, and in the last few weeks their eyelids have become really heavy. They believe it to be part of the fatigue, which is bad, but they're saying that at times they can't open their eyes until the fatigue has passed, almost like their eyelids are paralysed, so heavy and a struggle it can happen once a day. Is this an extension of the fatigue being really bad at times, feeling things so heavy in the eyelids?
I'm thinking that's most likely the cause. Obviously, I don't know you as an individual, and I think when you next see your doctor, make sure there's that heaviness in the eyelids not caused by something else. And in fact, one of the previous questions brought up a very rare disease, Myia Gravis, and that individual would probably know one of the things with myasthenia gravis is you get these droopy, heavy eyelids. So I'm no expert on myasthenia gravis, but that's one of the things we've all been taught as medical students. So, but it's most probably likely part of your broader fatigue. Could be PBC driven potentially.
Great, thank you. We touched on cirrhosis earlier there, but we have someone asking that once you develop cirrhosis, can that make your fatigue get considerably worse?
Mostly yes, because people who have cirrhosis from other causes, too much alcohol, hepatitis, other autoimmune hepatitis, cirrhotic patients tend to be very fatigued. And the more advanced the cirrhosis is, the more fatigued you get. And we see people who sometimes really trying to work and pushing through work, and they're really struggling with cirrhosis, and this is non-PBC cirrhosis, so because of fatigue. So yes, it would not surprise me actually.
Thank you. Question just around recurrence of PBC post-transplant, and if you do get recurrence of PBC post-transplant, is it possible that we could now take the new second-line medications that are available?
So yes, I wouldn't see why not. I don't look after transplant patients, but you would treat it as if you treat PBC pre-transplant, and everyone who has a liver transplant, certainly in our environment, so in Australia, they would all get. If you've got a liver transplant for PBC, you remain on urso post-transplant because it'll often control the disease. If that was not adequate in this day and age, I would almost certainly think it's very appropriate to go to a second-line agent, and I don't see why you couldn't have any of the second-line agents.
That's great, thanks. Could we just talk through, we've got a question about treatment options for itch. Could we just chat through what the treatment options are for itch?
Yeah, so itch, itch is challenging. Fortunately, there are a few more treatment options, for itch than there are for fatigue. So we are a little bit more optimistic around itch than we are for fatigue. So Questran, a bowel sequestrant agent, or cholestyramine is used. Urso, which people get, our patients get anyway, can sometimes help itch, not great, but sometimes. The fibrate, so fenofibrate or bezafibrate, we have fenofibrate in Australia, but bezafibrate or any fibrate agents, they as second-line agents with urso there's several studies now which demonstrate a decent, improvement in itch in a substantial number of individuals. We sometimes use an opiate blocking agent, naltrexone. I've never had great outcomes with that. There's an antibiotic called rifampicin, which is used for itch, and again, I personally haven't found it awesome, but it's certainly on the list of medications used for itch. People try antihistamines, that we don't see much benefit from antihistamines. There's an antidepressant agent called sertraline that has anti-cholestasis, anti-itch type properties, antipruritic properties. So you could use that's used, and there are clinical trials with its use. And more recently, there's and it depends where you are in the world. We don't yet have access, but there's in Australia, but there's a new drug called seladelpar, which is a PPAR agonist that works in the liver. Very, very good second-line agent for PBC, and they actually looked at itch scores in this cohort of patients, and 76% of patients had improved itch and pruritus, as the medical term stands. Great, so that's a whole bunch of information for you.
I think that's what's reassuring, is that there are multiple options for patients to try if they're experiencing it. So just make sure that you're discussing that with your doctor as well, and letting them
And
know.
keep discussing it, and be very clear if you respond and what are you satisfied with your response or not.
So that's all the questions that we've had sent in that we've covered this morning, which is great, because we've got another question that's just come in the chat as well. So if there's anyone with us in the room and you have any questions, please just pop them in the chat and I'll put them to Dr. Weltman for you. So
I see there's something in the chat. I can only see the second half of the question. So maybe you can read it.
Yeah, I'll read it out. Yeah. So it's again, noting that it's quite a complex question, but we'll cover it and then generalize the answer. So positive AMA and completely deranged bloods, including a liver function test 9 years ago. However, had sepsis at the time, and this has only just been disclosed to me now. I was not referred to gastro at the time, and no follow-up or even informed GP. I did not have any bloods for 5 years. However, the last 3 years, I have had significantly raised GGT with no other cause. My ALP only elevates slightly. I have in the last 6 weeks been diagnosed with PBC of my bloods, with a continued raised AMA and GGT. I have been commenced on URSO and my GGT coming down and right upper quadrant pain reducing. Liver fibroscan all normal and bile ducts dilated, awaiting MRCP. My problem is that I have a review by another gastro consultant who now does not think I have PBC and has put my symptoms down to menopause. I am unsure where I stand between the two consultants. Do you think it's PBC? This is a common thing with ladies.
Common thing. It's a bit challenging.
Yeah.
I don't think that's straightforward. I think those disturbed liver function tests in that scenario where there was sepsis many years ago is related to that, and you probably didn't need to see a liver doctor or gastroenterologist at the time because it was, that sepsis related. There was an underlying cause, and that's quite a common thing. In more recent times, the positive AMA suggests there's underlying PBC. Now, we see people with positive AMAs that don't need treatment. PBC hasn't declared itself as yet and may not. So there's some people who may never need treatment. The GGT should not be the main focus for PBC. It would be very unusual. The focus is a disproportionately elevated ALK phos. And this is a disproportionately elevated GGT, hence the second consultant is ambivalent about it. Mm-hmm. My thoughts are when there's uncertainty about this and you have a normal fibroscan, there's no rush to make a diagnosis in individuals like that, and no rush to label someone. And if there's an evolution to a high ALK phos, then it elevates in a persistent manner, then I would think this probably is PBC. And you can see how a whole lot of PBC symptoms overlap with a whole lot of with menopause or a whole lot of other health issues. Certainly taking the URSO, there's no downside to it, really. It's a very low risk medication to take if you feel better with it, and whatever the label is, at the end of the day. So that's not a bad thing to do. If I would just wait a while, and if it doesn't resolve, that's one of the few scenarios in this day and age. If there's uncertainty about a diagnosis, one would get a liver biopsy, and the liver biopsy findings would make it very apparent if that individual has PBC or not. The dilated ducts, the ductular system, is not PBC, and hence that's why an MRCP has been ordered, and that's quite appropriate. An MRC would be helpful in that scenario, as might a liver biopsy.
Great, thank you. We have someone just asking for a wee bit of clarity on the question that was asked earlier. So the question was about the bad fatigue resulting in the heavy eyelids, and you mentioned that it could be PBC related, but also something else. They're just asking if you could repeat that. I'm going to try and spell it because I'll type it in the chat because I've got it in my other question.
Could be lots of things, but one of the things someone brought up today is myasthenia gravis. And
Yeah.
somebody brought that up in the first or second question because they have myasthenia gravis. I think one of the individuals online
That's
today.
right. Yeah.
So, but there's lots of reasons for droopy eyelids. Myasthenia gravis is quite a classical one.
Great. I've popped that in the chat as well. So I just wanted to, just now that we've clarified that, I just wanted to touch back on the menopause question. So when you're having difficulty where there's this potential, I suppose it can be a bit of a pushback on patients as well to say that they think that it's menopause related. Any tips on how to handle that and how to?
Look, I think if the ALK phos is elevated, my view is that menopause can be part of the presenting picture, and the hormonal changes and what happens with menopause can be part of that woman's symptoms and presentation. But if there's a persistently high ALK phos, that's not menopause, and one should be fairly assertive and say, how do you explain the high alkaline phosphatase? And there needs to be, sometimes it's not PBC and we can't find a reason, and that's reasonable if it's been, as long as everything's been considered, and they'll say, I don't think it's all of these other things, and I don't know the answer, but I don't think there's a big issue. As long as all the possibilities, the specialist or doctors involved have considered all those possibilities, that's quite reasonable.
And I would just say if there are any patients who are in that position and struggling and need a bit of support, please reach out to us on the helpline. We can help with that as well, if you need a wee bit of direction.
But you're entitled to ask. It's not unreasonable, no doctor's perfect all the time, and so, well, I've explained your symptoms like that. If someone said to me, doctor, how do you explain that blood test abnormality? I might have a good explanation, but if I don't, that may alert me to say, well, maybe let's check a few more things,
Great.
You're entitled to, I think you're entitled to ask your doctor that sort of question.
And I think that can be a bit challenging for patients, can't it, if they have to have
it can be, yes. No, I suspect it can be, but I think, you should ask that question, and it's not, it shouldn't be seen as a threatening question to a medico. We're all busy, and sometimes we're not focused 110% as we should be. So I think it's not a bad thing.
Great, thank you. Just going to say that's us. We're up to date with our questions that we've had sent in and also in the chat here. So please, if you're in the room and you have any questions for Dr. Weltman, please pop them in the chat and we'll ask them. One thing that I just wanted to mention while we were chatting is as PBC Day approaches in September, our campaign this year is "You Are Not Alone." And when we were at the International PBC Summit in April, one of the main concerns that came out was mental health for PBC patients. Yeah. And I thought it might just be worth us having a wee chat about that this morning again. I think the importance of that can often be overlooked. And I think if you're suffering from symptoms, things like fatigue, or if your itch are really bad, that can have a real impact on your mental health as well. And I think it's just important that patients discuss that with their doctors.
I'd endorse. Yep.
Yeah, I was just going to say, in terms of signposting and that type of thing, what would you normally do in your clinic?
So, I think we always ask people, what else do you want to discuss? Because we go through a few things, and it's very busy. Our clinics are so busy, and they're not PBC specific because the volume's not there, but they're very busy clinics. But you always I think the best thing is to give someone a chance to say, first of all, we'll look at the letter. If they come with a letter from the general practitioner, if they're bringing up other issues, clearly look at that and what those issues are and whether they have a context for our illness or not. And often the general practitioner just wants to know if there's a context with what we're doing or not, then they may pursue that further. But sometimes people just suddenly bring up something, and I think the best way of saying is, okay, I've got to, we've gone through what I need to go in your situation, and now if you've got it, you should be feel free to ask me any questions or let me know any up-to-date information or concerns of yours, and take advantage of that, and if it's not, if the doctor thinks it's irrelevant to that, they'll get around to telling you, well, I don't think it's related, I don't think your broken left toe is related to your PBC, or your asthma is related. So, but no, just ask those questions. Just those are ridiculous examples, but just ask those questions, and the same would go for mental health. That's
I'm just going to
health. Just see it as health and ask those questions.
Yeah, and I think that's the important part, isn't it? Is to make sure that that you're bringing it up and you're talking to.
Because they may not know, like for most of our patients, we don't see them that often,
Mm-hmm. So the document there that I just was checking, I had a copy of in my bookcase, is
that's a good thing as well.
To appointment prep, because I think often as well you can turn up at your appointment, and if you're feeling a wee bit overwhelmed, you might forget. So I think even just in the lead up to your appointment, there's notes here for thinking about questions to ask, and just note how you've been feeling, and consider your mental health as part of that. And take a note of that to ask at your appointment. So that's the appointment prep one, and then also
that's a good sheet.
Mm-hmm. And also sitting alongside that's the discussing PBC with your clinician. So that's more around checking are you on the right dose of urso and that type of thing. So
and it depends on the expertise of your doctor, but you need to help them help you. So that's sometimes all these things are helpful. And people who don't like all that paperwork, if you've got a mobile phone, you've got notes here today. And people, I just tell them, put it in the notes, and okay, I need to ask these questions because I haven't seen my doctor for 6 months, and every few weeks I've added another point. Yeah. And then half the time they look at it, actually, most of those questions are already answered just in the consult, just by having the consultation. But I did want to ask you this, doctor.
And we also have the
made
app.
A note of it. It's quite useful because then it allows you to get straight to the point.
Definitely. And we also have the app as well that people can use to track their symptoms and note questions for appointment as well. We're working on upgrading our new app, and we're hoping to have electronic versions of these in the app as well, so that people can quickly access that on the go as well.
And you can and like it depends on the nature of your doctor's practice, and if they're in a big hospital, it's a bit more challenging. But if they're in the private office, you can sometimes send information ahead. This is what I want to discuss.
Mm-hmm.
And I think, if they've got not every doctor's got time, but if they've got time to look at that, that helps them say, okay, I can see where what's really bothering that individual. We better deal with that issue.
Mm-hmm. I was actually at the summit as well. I was chatting with one of the nurse specialists who leads a PBC clinic, and she'd said that in the lead up to appointments, they send stuff out to patients ahead of time to arrange to get their bloods done at their local surgery, and then when they come in, and they're going to start sending out our leaflets with that as well. So encouraging the patients to get prepared for going.
That's probably a good idea.
Yeah. We like that. Yeah, we thought that was great.
There's another question there.
Yep, another question in the chat. Could I ask why regular GP does not understand that PBC can elevate LDL cholesterol, and therefore they make you feel bad if you do not get on with statins?
I don't know why they don't know that, but PBC is not a common illness, so they don't know all the nuances really, and that's really, the key thing is the ALP. We're grateful if the GPs know an ALP and AMA. Really, if most GPs knew that would be, I think Mo would probably endorse this in a global sense. That would be extremely helpful, because we would miss very few patients if they knew that. Mm-hmm. And if patients have hyperlipidemia, I indicate in my correspondence to the GP that people can get a hyperlipidemia that might have PBC, and they were going to get hyperlipidemia anyway, unrelated to their PBC. So it might be unrelated, but it certainly might very well be related, like you have illustrated there in the question. And So the GP needs to keep an eye on the lipid profile, and at some point, if that shouldn't make you feel bad, but at some point one may need treatment for the hyperlipidemia, because the consequences of persistently high LDL levels. So at some point, one may need to have lipid lowering treatment. So it might be very mild hyperlipidemia that actually responds to an old-fashioned fibrate, which would help the PBC, but people may need statins, or there's a whole bunch of newer medications that are coming to the market that may be necessary to treat the hyperlipidemia. Not all hyperlipidemia needs to be treated, but it may need to be.
Thank you. I'm looking at time here, and I know I always like to give Dr. Weltman time back, because it's afternoon for Dr. Weltman, and we borrow him right in the middle of his clinic. So I do, if we've got spare time, I do always let him get back to his patients. But I will hang fire for a few more moments, and just see if anyone has any questions that they want to pop in for us.
Yeah, please ask.
Yeah, please pop the questions in.
There's no embarrassing questions.
No, that's the thing. There's no stupid question. That's exactly it, and I think that's why it's remained popular 5 years on, that we're still receiving questions every week.
Yeah, no, we do. We still receive. Some of them are the same, some are new, and it doesn't really matter.
And I think sometimes when you've got when we're seeing the some questions that are repeated that come back in again, then that's someone that's been newly diagnosed and has reached out.
Or new people join the foundation or engaged. Yeah. And they're not familiar, and that's why it's fine. How often should you have your bloods checked when taking URSA? As a general rule, it's more determined by the ALP level, how high your ALP is. As a general rule, I bring people back at 6 months. And then if they're starting to have a good response, 6 monthly. And if I'm concerned about a very high level, and I'm thinking my instincts are there's a whole lot of other bad prognostic factors, like someone's very young woman or a male, that tend to have, there's many alarm bells that they may do poorly. For example, I might bring them back soon if their levels are very high, but you've got to give URSA a chance to work. And it doesn't work overnight. Usually, we have one person said the ALP came down very quickly, and that's very fortunate. But it doesn't always work very quickly. It's a very slow working medications.
And just while we're talking about routine tests and checks, how often would you suggest a FibroScan?
So it depends again on the initial FibroScan findings and the concern about the severity of liver disease. If someone's got a very low level, no fibrosis, a liver stiffness score of less than, say, 6.5, I probably wouldn't do it for a good few years, assuming they have a good response to URSA. So everything normalizes. I wouldn't rush and repeat it. Someone who has a high initial FibroScan reading or other biochemical features of more aggressive liver disease, like quite disturbed liver tests that don't settle very quickly, I might bring them back in 12 to 24 months, depending on the resources. Every place has different resources and clinic waiting lists to repeat the FibroScan.
Great, thank you. Any other questions for Dr. Weltman? Just give it a few minutes, Doctor, and see if anyone else, and then if not, I will give you back to your patients for the rest of the afternoon. I think we've got another session booked in with you. I think it's next month we're booked in again for another.
Oh, okay. Yes.
I'll keep you posted and send on the notification for the time again.
Yes, very good.
But I think we'll wrap that up for today, Doctor. Go and we've got someone typing. I'm going to give it a last chance.
Let's just give them an opportunity before we.
Oh, it's a thank you. So we will take that, and I will
always a pleasure.
Thank you so much for your time, Doctor, and we'll see you again.
We enjoy doing these, and it works well. Foundation's done them for a long time, and Mo's taken this on with a great level of enthusiasm
I
from
do love
Robert.
her
So,
Q&As, yeah.
yeah, she keeps us on our toes.
I try.
Yes.
Right, thank you very much, Doctor. Take care.
Bye-bye,
See you
everyone.
later. Bye.